Well, good morning, or whatever time of day you happen to be watching the show. Uh, Welcome to another episode of Issues That Matter. And for those of you that have watched the show in the past, you probably realize that one of my focal points is to help simplify people's lives. And we do that by one of the ways that we do that is by taking advantage of the gems that we have right in our own backyard. And today I'm honored to have Dr. John VELLA, director of the MAINE Transplant program out of Maine Medical Center, Maine Health. Dr. VELLA, welcome.
Thank you. Good to be here.
Nice to have you here. What was the genesis of the transplant program?
So kidney transplantation has been the treatment of choice for patients with kidney failure for many years, decades even. And the Maine Transplant program predated my arrival in Maine, started in 1973. And it's had a long and successful history. I joined the program in 1999 to take up the leadership at a time when the program had gone through a lot of transitions and staffing. And so I've been here for the last 16 years, and I've been the director of the program pretty much ever since. So it's been a very interesting time. We've had a lot of growth, a lot of successes, and it's we're running a very successful program. I think we're offering the people of Maine a first-rate experience and great outcomes when they need a kidney transplant.
Now, it's the Maine Transplant program. In reviewing the website, it seems to focus a great deal on kidney transplant.
Yeah, we only do kidney transplant. In fact, we're the only transplant program in the state. The state of Maine is a large state with a small population. It's not big enough to support a heart transplant program or a liver transplant program. We previously performed pancreas transplants, but again, our numbers were not, we didn't have enough of a referral base to meet the minimum volume requirements to stay active. Yeah,
so I would imagine the infrastructure for a program, for a wider ranging program would be quite costly.
And yeah, and it's not even that. It's the bigger issue is, in order to be a successful program, you got to be doing a minimum volume of whatever the procedure is. With volume comes expertise, better outcomes, fewer complications, and there isn't the same need for other types of transplantation within the state of Maine. So we're focusing on kidney transplant, and I come to this as a kidney, I'm a nephrologist. I'm a medical kidney doctor by training. And that's what the biggest need for is within our catchment population, which is basically Maine and to some extent southern New Hampshire as well.
Yep. So kidneys are the big picture, so to speak.
Sure.
For the program. How many people comprise the program? How many, the staff, doctors, and so forth?
So we have a large multidisciplinary team that straddle various different areas within the institution. We have an outpatient facility. Obviously, we have the inpatient facility. We have excellent support from our tissue typing lab. In terms of physicians, we have 2 transplant surgeons. We have 4 transplant nephrologists. We have 4 nurse coordinators. We have nutrition support, pharmacy, financial coordinators, office administration. We have our tissue typing lab. It's a large number of people, and plus there are other individuals with whom we interact all the time. For example, the nursing staff on the inpatient side, and all of the other individuals that make up our team.
Now, what is nephrology?
Nephrology is the study of medical kidney diseases.
Okay.
So basically kidney diseases that lead to conditions like high blood pressure, protein in the urine, chronic kidney disease, kidney failure. And then how do you deal with kidney failure? Dealing with things like dialysis and of course, what I do, which is transplantation.
Yep. Yep. And how many transplants have been done, if you want to say in total, if you want to say the last few years?
So that's a great question. So we celebrated our 1,000th kidney transplant here in Maine in 2003. And since then, we've probably done another 1,500, another 500. So in total, we're north of 1,500 at this stage
So if
since inception.
if anybody's going through the MAINE transplant program, they're dealing with experienced people.
Oh, absolutely, absolutely. Yeah, we have an extremely dedicated, experienced staff who are all, completely immersed in the program, but also in what they provide for the patients in terms of their own speciality.
Yep. And how does the process start?
So when an individual is found to have advancing kidney disease or they have irreversible kidney failure and they're already on dialysis, their local kidney doctor will refer them to the transplant program for transplantation. And so we will meet these individuals, and we start out by offering a lot of patient education. So we point them to our website, we bring them in, we give them a class, we give them a book. And we view patient education as being fundamental to everything that we do. So it's not just the class or the website or the book. We have iterative processes whereby patients have an opportunity to interact with the team and ask questions, and we then focus in on certain particular items as we go through the process. So for example, once somebody actually gets their transplant, we then switch the teaching resources more to focus on things like medication management, which is hugely important after transplantation.
Now, what type of medication would be involved in that?
So most patients require combinations of 3 different oral anti-rejection medicines that need to be taken in an unbroken chain from the time of transplant, basically forever, or at least until the kidney fails, if it fails at some point, down the road. In addition, most patients, at least early on, need to take 3 different antibiotics. And most people end up on various other medications to control things like high blood pressure, for example. So most of our transplant recipients are doing well, they're free from dialysis, but they're taking a bunch of meds. So in addition to patient education, that we put them through a full evaluation. They get seen by the physician staff, by the nurse coordinators, and by every member of our team. And it really is a multidisciplinary approach to care. So they need to meet up with the pharmacist and the social worker and the nutritionist and other members of the team, so that we're not just evaluating them, we're trying to identify what their gaps or weaknesses may be before transplant so that we can best support them afterwards so they're going to do well.
Yep.
We put them through a whole bunch of testing, blood testing, heart testing, other tests. And ultimately, once we've compiled all of this information, we have a formal process. We have a selection committee every couple of weeks. It's a very formal process that, by the way, is required by the various federal and national organizations that govern transplantation. And then we can add their name to the waiting list for a deceased donor kidney transplant. And hopefully, in the meantime, we will also have been asking questions about whether the individual has a potential living donor. Because, of course, if somebody does have a potential living donor, then that would have good implications for their potential waiting time for transplant and outcomes afterwards.
What is the process? A person comes down and it's determined that they need a kidney transplant. How does the process start?
So it starts with a referral from their kidney doctor.
Okay, you get the referral, goes to you folks, see them.
Right, and then we have a standardized approach to evaluating candidate transplant recipients. So we start at the beginning. We literally have a pathway. We start at the beginning, where they're referred. We review their medical information. We bring them in. We give them a class. We sit down with them, review their history in person, do a physical examination, organize a bunch of tests, make a decision about their candidacy at a transplant candidate review meeting, get them waitlisted for a transplant, and then ultimately offer them a kidney, whether it's from a living donor or a deceased donor. So we start at the beginning and work our way through each step until we get to the desired goal, which is transplantation.
Okay, now looking at the process from the perspective of the donor, what does the process look like? What should a potential donor be expecting?
So we're talking about living donors here, of course.
A living donor.
So living donors also have there's a process, there's a pathway to living donation, and it generally starts with the living donor calling us and say, hey, I hear that somebody, it may or may not be a family member, but somebody needs a kidney, and I think I might be a candidate to offer that person a kidney. And so we will take that person's information, we'll work with them. Again, we'll review their medical history. They'll have some blood and urine testing done. They'll come in, meet with us. We'll go on and get some imaging of their kidneys to make sure their kidneys are structurally normal. And ultimately, we get to the point where we, again, will discuss them at one of our selection committee meetings, and hopefully they'll have met all the criteria for organ donation, and then we'll be able to move forward with the actual nephrectomy, which is the procedure to remove a kidney from a living donor.
Now, from what I've gathered in what the research I did, the MAINE transplant program is thought of very highly in that world. The results are very well, compare very well with other programs across the country.
Yeah, absolutely. So transplantation remains one of the most highly governed of all medical specialties. We are beholden to the United Network for Organ Sharing, which is the national organization that governs all types of transplantations, and also to Medicare, it's Centers for Medicare and Medicaid Services. And so we answer to two or more masters. And as part of this, we are obliged to provide data on our outcomes. We must, under penalty of fines, et cetera, we must provide data on how our patients are doing. And so therefore, we actually have top quality information about not only how our transplant recipients do, but how the people on our waiting lists do, because that's the other part of the equation. It's all well and good to just cherry pick and do the healthiest transplant recipients who are going to do well, but really what we really want to provide is the best outcomes for the most patients. How effective are we at getting somebody who needs a transplant to the point of actually receiving a transplant? And so we have this data. It's all, by the way, it's all freely accessible. You don't need passwords. There's a website called the Scientific Registry of Transplant Recipients. So if you go put in srtr.org, O-R-G, then you can look up every transplant program in the nation. So you sort it by state, and you can pull up MAINE transplant program. And when you look at this data, you see that not only is our data shown, but our data is described in relation to how other programs are doing, not only throughout the rest of the United States, but also throughout the rest of our region, which is basically New England. So you can see that our waiting time for transplantation is, some number, and the average program in New England has another number, and the United States as a whole has another number. So this is all, furthermore, all of this information is adjusted statistically according to what sort of patient population do you have. Because clearly, we might have a different patient population in rural Maine as compared to urban Boston, for example. So there are obvious differences. So all of this data it's not just raw data, it's case mix adjusted. So there's a few things that I look at, because this data is updated every 6 months, and there's a few things that I really focus in on. One question is, how many people do we have waiting for transplant? And the answer is, it's about 100. And we get about 150 to 200 new referrals a year. Not all of those people are going to be healthy enough for a transplant, but most are. And at any point in time, we usually have about 100 people waitlisted for transplantation. The second question for me is, how are we doing? I mean, are we getting these people transplanted? I mean, that's a hugely important question. So what's our transplant rate? What proportion of our people on the waiting list are actually making it all the way through to transplant? And so when you compare Maine Medical Center's transplant rate with our competitors, frankly, in Boston and throughout the rest of New England, we're running about twice as high. So we're managing to get more people on our waiting list transplanted every year through a combination of living donation and deceased donation.
Given the makeup of our population, because I do know, and as you've indicated already, we're a very rural state.
Right.
And the question that bounced into my mind a moment ago was the post-care that takes place. I mean, I can understand the kidney transplant, you have to go to the hospital to have the transplant done.
That's a great question.
The post-care, if you're coming from Aroostook County,
Right.
Or coming from Western Maine,
Right.
I could see that as being and having multiple sclerosis, that's an issue.
Right.
That is an issue. I could see that being a critical issue. How do you folks handle that?
So we're the only program in the state, and we're the only place where we have focused expertise in transplantation. And that means that patients have to come to us. We don't have the resources, nor would there be the population base to support a transplant clinic in Aroostook County, as an example.
Yep.
And so I mentioned that patient education is a big part of what we do. That's one of the first things that we tell patients. If you get a transplant, the care is going to be focused in Portland. So they have to come see us. And that's a huge commitment, especially early on post-transplant, because while the length of stay in the hospital is fairly short, the frequency of visits to the transplant center after discharge, particularly early on, is frequent. As an example, we're seeing our patients twice a week for the first month after transplantation. And the goal during this high frequency, high intensity period is to make sure that they're taking their medications correctly, that we are dose adjusting their medication. These are dose critical medications. These are level, blood level critical medications. And that we are addressing complications early and effectively before they create a problem that's going to lead the patient to be, to get sick and be readmitted to the hospital, maybe need another surgery or whatever. So that's a challenge when we have some people who are driving 5 hours from Frenchville or Presque Isle. But that being said, when these people, if they do end up with an emergency situation and they do arrive in a small local hospital, they don't have the expertise or the resources to look after these people. So in an emergency situation like that, they invariably will be referred down to us. They'll be transferred from the local hospital to the transplant program. And we can streamline their care and do it, look after them and make sure that we get them back on track quickly with the least risk of other complications occurring. It's a huge challenge when somebody is living that far away. We do have a local, there's an inn across the road from the hospital where we can put people up short term after discharge. That can be actually very, very helpful for people who live the longest distance away to prevent them needing to travel when they've just very recently had surgery, when they're recovering from all of this stuff. Longer term, for people who live a long way away, we actually have very strong relationships with the referring nephrologists, with the local kidney doctors. So once people get out 6 or 12 months, very often we can alternate care so that, you know, we're seeing them one visit and maybe they'll see our colleague in Bangor, for example, and so that'll reduce the traveling long term. But
I was just thinking about Eastern Maine Medical Center.
Right.
You know, that's a
That's a great example.
facility.
So we do have a strategy to, you know, help people out in that regard long term, but still their medical home for transplant is going to be with us.
Yep. And that's unavoidable.
Well, you know, this is what we do.
Yeah.
And
To do anything else would create a unaffordable have an unaffordable infrastructure necessity.
yeah, but we have great relations with our relationships with our referring docs, many of whom, by the way, we've trained. So you know, they'll call us, they'll call me. You know, if somebody's getting into trouble, they'll give me a call and say, hey, what are we going to do with this problem or that problem, and we'll figure it out.
Generally speaking, a person has a kidney transplant. How long are they going to be in the hospital?
Average length of stay is about 3.5 days.
That's incredible.
It used to be 9 days. One of the things that we've been working on over time is our initiatives to shorten the length of stay, to reduce the risk that somebody would need to be readmitted to the hospital after a transplant or after they had been hospitalized for a subsequent complication. And you could say, well, you know, is 3.5 days too short? Well, it turns out that, you know, being in hospital is being in hospital. It's, you know, it's a great place to be when you must be there, but most people don't really want to be in hospital. And if we can look after individuals and achieve all of the tasks we need to achieve in a shorter period of time, that's to their benefit. And by the way, we never kick somebody out until they're ready to go. So we pack a lot of stuff into a short period of time after transplantation, and that's where the team comes in. So everybody has a role. It's important that the patient knows their meds, that they have the money to travel to and from clinic. You know, sometimes you need to provide them with gas cards or whatever. That their secondary insurances are up to speed. That's what our financial counselor does. That they're eating the right stuff and are not trying to not inadvertently putting themselves at risk because of poor diet choices, as examples.
Okay, now you mentioned eating the right stuff. What would be a typical after post-surgery diet be?
Oh, heart-healthy diet. A low-salt, heart-healthy diet, simply put.
Okay.
Yep.
All right. Let's see here. I had another question bounce around in my mind, but as we talked in the green room, MS fog, it rolled in on me. What are some of the points of reluctance that a potential donor might have?
So again, when we think about donors, we've got living donors,
Donor,
and we've got deceased donors. So, well, if you think about it, if somebody's walking around with 2 kidneys, if they want to donate, they're going to have an operation. They're going to need to be hospitalized. And by the way, most living donors spend about 2 or 3 days in the hospital as well. So there's, you know, it's a big surgery. There's the need to be hospitalized, obviously general anesthetic. There's the small risk of complications. There's the recovery time out of work. So these are all potential barriers. So these can be overwhelming barriers for some individuals, and for other individuals, they can overcome them. Obviously, our goal is to try and make the process as seamless as possible to reduce the size of the barriers. Because, of course, if you have a potential living donor, then for the intended recipient, mean, this is transformational. Shorter waiting time, faster recovery, sometimes need for less immunosuppression. And whatever way you spin it, statistically, living donor transplants are more durable than kidneys from deceased donors.
Now, from a potential donor's perspective, and this may sound harsh, but I can envision somebody thinking in the back of their mind, if I'm a potential donor, they may not put as much effort into saving my life as they would otherwise. Or something along those lines. I might not be wording that as well as it should be.
So now you're talking about deceased donors, I presume, or?
Well, you know, a person might not want to be on a donor list, or might not want to might not be on a potential donor list.
So now you're talking about deceased donors. So,
because they think that they I don't know, they think that this is an opportunity to get a donor, to get an organ.
So people have the opportunity when they go to the DMV, when they're applying for their driver's license,
Exactly.
to sign up to be a potential organ donor in the event that a medical catastrophe happened and they were not going to survive. And so somebody can tick a box and say, yes, if I'm dead and my organs are usable, please use my organs. People sometimes express concerns that maybe if you're signed up to be a kidney donor, that the medical team caring for that individual when they're having their medical catastrophe may not go all out to save them so that their organs can be used. I've never understood this one. I've been in medicine for a long time, and first off, if somebody's, and this is always in the intensive care unit situation, the discussion about limits of care are made based on the situation that the individual has found themselves in. As an example, if somebody was involved in a catastrophic motor vehicle accident and had irreversible brain injuries and they're on a ventilator, they are going to meet criteria for brain death. So they are legally dead. Mm-hmm. And it's at that point when a decision is made that they are dead, then the question comes up, well, this is awful, but maybe it's awful for this individual, maybe some good could come out of this for somebody else. And that's how these things evolve. So you've got two very different decisions, but the first decision is this individual is dead. They meet brain death criteria.
Clinically dead.
There is another category of deceased donors who don't meet brain death criteria, but a family may decide that the individual is not going to survive whatever injury or process that has led them to this situation. And a decision may be made that life support is going to be withdrawn. And under those circumstances, once the patient has clinically died, I mean, in other words, the heart has stopped beating, a decision may have been pre-made that organ donation would occur after natural death has happened. Mm-hmm. Either way, organs will only be procured from a deceased donor once they've died. Very important point to consider. So there's no mixed messages here.
Good. Well, it sounds like it's you might say a logical reluctance.
Right.
But at the end of the day, it's not the case. It's clearly not the case.
As is the case in many aspects of transplantation, this is highly regulated, supervised, vetted by ethics committees. Most transplant hospitals will have deceased organ donor committees who are separate from the actual, in other words, I'm not part of our organ donor committee. I deal with the other side of the coin, so to speak. So ethically, morally, from a religious point of view, there are the concept of deceased organ transplantation is broadly accepted, and there should never be concern about mixed messages or people getting suboptimal care because they may be an organ. And that is absolutely the case throughout the United States, Europe, and in fact most of the world. Not every country, but most of the world. Certainly the Western world.
Yeah. Well, it's now, and I raised this question to you before we went on the air. You have some acronym after your name. Now, the MS-FOG has not deleted my knowledge of what an MD is, but you also have the FACP and the FRCP. Why don't you tell us uneducated people about acronyms, what they are?
So I'm a fellow of the American College of Physicians, and because I did my early training in the British Isles, I'm also a fellow of the Royal College of Physicians. So it's just stuff.
Well, yeah, it may be just stuff to you.
Yeah.
But if somebody is dependent upon a person such as yourself for their life,
Right.
knowledge of what these acronyms may mean could mean an awful lot to them.
Sure. Well.
And you should be proud of them.
Sure.
They may be acronyms to some, but this is they don't just happen.
It allows me to do what I love doing. So.
How long have you been doing it?
So, well, I graduated from medical school in 1989, and I've been involved in kidney medicine and transplantation, actually right from the beginning in my internship. So
you graduated medical school in 1989. I'm not going to say how old I am, but you're a youngster.
I've been doing this for long enough.
I guess so. Oh yes.
20.
No doubt. And you don't
25 or 26 years. How about that?
You don't get acronyms like that.
All right.
Without a lot of experience.
There you go.
Okay. What would be a takeaway idea, a takeaway thought?
So I think for a take-home message for a broader audience is that transplantation is life-saving and is completely dependent upon the availability of organs for transplantation. To underscore that point, right now in the United States, we have approximately 120,000 people who are on waiting lists for various types of transplant: kidney, heart, liver, lung, pancreas, small bowel to much lesser extents. Most of those people are waiting for kidneys. And every year, all the programs in the country collectively perform about 20,000 transplants. That's a big gap. And for the 100,000 people who don't get transplanted, there's a death rate. About 12 people die every day waiting for a transplant. And so we're looking to expand the number of living donors. We're looking to expand the number of deceased donors. The real point is, when you have the opportunity to sign up at the DMV to be a donor, I would encourage everybody to do it. I've done it. My family members have done it. Everybody in the program is signed up to be a deceased donor. That's the single most useful thing that individuals can do that may ultimately have an impact on somebody else's life. Don't forget, one deceased donor can potentially save up to 8 lives. If you think about kidneys, heart, lungs, liver, and so forth. Okay. So one deceased donor can have an enormous beneficial impact. And this is an individual who's died. That there's nothing good about somebody dying, but this is one potential good that could be an opportunity for people in need.
And what I'm hearing and what's rattling around in the caverns of my mind is that the concept that we are our brother's keeper carries on even through death. Because through organ transplants, organ donations, we can help our brothers who might be otherwise passing on.
Oh, absolutely. And I, primarily as a kidney specialist, I see people who are struggling with dialysis. And don't get me wrong, dialysis is an amazing technology that keeps people with kidney failure from dying, but it's not easy. It's a huge time commitment. People develop a lot of symptoms during their dialysis treatments. They have an increased risk of infections, risk of hospitalizations and other problems. So dialysis will keep you alive. Quality of life is diminished. And if that individual has then the opportunity of getting a transplant, they're going to feel better. They're going to have a lower long-term risk of dying. They're much more likely to be a productive member of society and support themselves, their families. And for the people in the audience who may be fiscally conservative, the long-term healthcare costs associated with transplantation are very much lower than associated with dialysis once you get over the kind of the equalization phase. So you feel better, live longer, fewer healthcare costs. It's clearly the way to go as long as the individual is healthy enough for a transplant. The other observation is that many people who find themselves in the situation of having kidney failure already have a lot of pre-existing medical conditions that would increase their risk. So for example, if somebody has cancer, suppressing their immune system would be a terrible idea because their risk of developing worsening cancer that spreads or metastasizes is going to be much higher. If somebody has underlying infections, they're not going to be a candidate to have their immune system suppressed, pretty much for the same reason. So the proportion of people who are offered transplants it's about 20% of the dialysis population, because the rest have, it's not an ageism issue. We don't exclude people because of age, but we do unfortunately have to exclude people because their heart function isn't good enough, or they have cancers or infections or some other problems that really prevent us from being able to offer this wonderful treatment, but it's a treatment that is associated with need for immunosuppression and risk of complications. And going back to where we started, that's also one of the things that we teach our patients. There's no such thing as a free lunch. And in this business, it's anesthesia, surgery, and immunosuppression. And it's, if you look at it in totality, most of the complications that we see relate to the immunosuppression. Manageable, we deal with this stuff all the time, but it's very real. And that's a big part of what I do, is making sure that the kidney's working and the patient is doing well, and we're dealing with complications as they develop. We haven't learned yet how to transplant people without immunosuppression, unless of course somebody has an identical twin, right? And then it's just a surgery, and that's easy. We've actually done one of those. That's kind of cool, but that's another story.
You can come back and tell about that another
well,
time.
That's another show.
Yeah.
Right? So the vast majority of people need immunosuppressive therapy. Otherwise, the kidney or the heart or the liver is going to reject, and it's all over.
Do you get the sense that there are a lot of people out there that know about this program?
I think so. We've obviously focused our efforts on reaching out to the populations that need us most. So, These are the staff at the various dialysis units around the state, at the referring nephrology offices around the state. I mean, there are numerous kidney medicine groups scattered throughout Maine. And so we've done a lot of outreach. We've actually just, visited our colleagues right throughout the state to give them updated information on the program, how we're doing, and making sure that, we're all on the same page about expectations. Of course, this is a very different opportunity, but I think we reach out in a very focused way to our referral base effectively. But hey, outreach is very important for all sorts of reasons, and boosting the number of potential donors is always critically important for us. Yeah.
Well, speaking of outreach, I want to let you know that anytime that you folks think that being on this show, or I would say any of the shows that Bedford Public Access has, give us a call.
Right.
I would love to be able to help you get that word out.
Yeah, and from the transplant program point of view, if people are wondering whether they'd be better off going to Boston for their transplant, our waiting times are shorter, our transplant rate is higher, our outcomes are as good or better. You can stay here, you don't have to drive in Boston. We've got a great team, and everybody in my team is completely committed to this program. We all have the same goal. Simply put.
Thank you for bringing that up. That's the MS fog rolled in again. That was going to be one of my questions, but thank you for bringing that up. And that's one of the, as we talked about in what I referred to as the green room earlier. Back 26, 27 years ago, the thought was, if you have a significant healthcare issue, you got to go to Boston. Well, maybe 26, 27 years ago, that might have been the case, but that's not the case today.
Well, they can look at the numbers. I mean, unlike many other specialties, you can actually, you can go to the srtr.org website, and you can look at my numbers, and you can look at MGH's numbers, and Tufts Medical Center, and if you want to, you can look at UCLA. I mean, you can look at every program in the state, and you'll have the data displayed in the same way, and you can see what's their transplant rate, what's their waiting time for transplant, what are their outcomes looking like, and you can make an informed decision.
Well, I want to thank you for what you folks do.
You're welcome.
You save a lot of lives, and you make not only the lives that you save, but the lives that you save and those people whose lives get touched by it. You make their life that much better.
That's our goal. That's our goal.
Yep. Well, thank you very much, Doctor.
You're very welcome. And you.
And I look forward to having the opportunity to having you on the show again.
Great.
Okay.
I'd be happy to do so.
I'll be happy to have you. We'll set a date. Folks, that's the show. I hope you enjoyed it. I did. I found it fascinating, enlightening. I have some additional shows in the works, so stay tuned. And until the next time, have a safe time and do what you can to simplify your lives. And taking advantage of the gems that we have right in our own backyard is one of the easier ways to simplify your lives and has benefits to other people in your neighborhood or in your area. Thank you, have a great day, and make it a safe one. Bye-bye.